Good morning, everyone. How are you today? I hope you all fine, great, and good today. So, welcome back to the 4th International Seminar and Workshop on Public Health Action with the theme Ensure a Healthy Life supported by Sustainability, Energy, Environment, and Health Literacy in the era of Society 5.0. And welcome back to Honorable Dean of Faculty Health at Dian Nuswantoro University. Thank you for your coming. And honorable speakers, Dr. Anu Sugihanto MKes as Chairman of Provincial Committee of Indonesian Society for Health Promotion and Education or ISHPE. Mrs. Christine Sorensen as Executive Advisor on Health Literacy, Service Hong Kong Polytechnic University. Ms. Angela Yi Am Ling, Professor and Director of WHO Collaborating Center. And all participants today, okay, and including those who joined today via Zoom meeting, there are hundreds of participants, of course, from various countries today. So thank you for joining today. And ladies and gentlemen, this is the second day of ISWOPHA 2023. Today we will again present you with extraordinary speakers. And that is, of course, only at ISWOPHA. Yay! So I'm not alone because there will be a moderator accompanying the speakers. He is a researcher in the field of digital health literacy. He is also a lecturer at the Faculty of Health Dian Nuswantoro University. She is Miss Ani Rahmani, SKM MCom PhD. And for the curriculum vitae, in more detail, we will display it on the LCD screen. So ladies and gentlemen, please welcome Mrs. Ani Rahmani, SKM MCom PhD.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good morning, ladies and gentlemen, also distinguished guests and also esteemed speaker. It's an absolute pleasure to welcome you to the second days of ISWOPHA. I'm honored to serve you as your moderator for this event. I promise that this event will be a rich exchange of ideas, also insight on the topic that we can we take home message for individual and also in the societies. Healthcare is a fundamental human right, and the issue we'll be discussing today in this conference. In our rapidly evolving world, the complexity of healthcare system, the need of effective of health insurance, the importance of health literacy, and also the promotion of healthier lifestyle have never been more critical. The theme of this conference underline interconnected of this key element. Because health insurance provides a safety net, ensuring that all individuals have access to necessary medical care without financial problem. Health literacy empower individuals to make informed decisions about their health, navigate healthcare system, and also understand the value of preventive measure. And the health promotion encourages to adoption of healthy behavior and also lifestyle, reducing the burden of healthcare system and also improving overall well-being in our purpose. Over this morning, we will have the privilege of hearing from the expert and thought leader who have dedicated their career to advance this critical aspect of the healthcare. They will share their knowledge, research finding, and also practical solution to some challenges we face in the realm of healthcare and public health. I encourage all of the participants, offline and also online, to actively in this discussion, ask questions, and also share your own experience and also insight. So, without further ado, let us begin this journey of exploration and collaboration. For the first section, we will invite Dr. Lily Krishnawati, MKes, the Director of Health Service Insurance, BPJS. Can the admin share the CV? Dr. Lily Krishnawati. Dr. Lily Krishnawati is a Director of Health Service Insurance. She got certification in Qualified Risk Government Professional, Chief Government Officer from BNSP. She has excellent skill in INAZI-BIJIS, DRG, clinical pathway, coding ICD-9 and ICD-10, and she have become trainer in coding ICD in around Indonesia. She was President Director of PT Cokro Cendeka Indonesia, President Director of PT Bakti Putri Satmoko, and many presidents. And now, she is the non-permanent lecturer of Ministry of Health Polytechnic Semarang. I invite Mr. Lily Krishnawati to share your presentation. You have 20 minutes to present. Time is yours.
Thank you. Am I clearly heard my voice? It's okay?
Okay, we can hear you.
Thank you. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Peace upon all of you. Distinguished guests, lecturers, and officers of University of Dian Nuswantoro, all speakers, and everyone that has joined this morning. I see Pak Anung, I'm sorry I cannot attend directly due to my other duty. But first of all, I would like to congratulate the committee of this event from University of Dian Nuswantoro. It is a very excellent job, and it's been very honored to be here right now, and I really like to congratulate for this great event, and I hope all the events are going smoothly and you reached all your target goals that has been set up. And I'm very proud to become a former lecturer in Dian Nuswantoro also. Allow me to share some of the program of National Health Insurance, or we call Jaminan Kesehatan Nasional, or JKN. Slides. Okay. The National Health Insurance Program. Sorry, I cannot see it first. Okay. Yeah. Slides. Okay. The National Insurance Program, known as JKN, Jaminan Kesehatan Nasional in Indonesia, have run since 2014. In implementation of this program, collaboration between stakeholders, between health facilities, members, BPJS Kesehatan, and even also the policymaker becomes an important part to make this program a success and in order to make it sustained. As National Health Insurance Administrator, BPJS Kesehatan takes role in revenue collecting, strategic purchasing, and also risk pooling. As a revenue collector, BPJS Kesehatan collects the premium of national health insurance from several parties. The first is government, who pays the premium for poor and near poor people, or we call it penerima bantuan iuran. The second is from employer, who pays their contributions as some percentages of their employees' salary. Jadi penerima pemberi badan usaha ini juga membayar kontribusi. And the third is employee itself in formal and informal sectors who pays their own contribution. Jadi semua pegawai formal dan informal juga membayar kontribusi. As strategic purchaser, BPJS Kesehatan will contract some of health providers in primary and referral or advanced care setting. Contracted health providers have to deliver health services to the JKN member according to medical guidelines and medical indications of the member. Contracted primary health care facilities are also obliged to deliver personal promotion and prevention for their members. The second, as risk pooling, BPJS Kesehatan expand the membership to achieve universal health coverage. The more members registered in JKN program, the lower the risk of managing this program. BPJS Kesehatan also provides the promotive and preventive program to all members in order to contain the cost of health service and ensure the sustainability of the program. So in Indonesia, one of the implementation of the principles of gotong royong or cooperation between community is really reflected by this program of JKN. Each stakeholders of the JKN program needs to understand the regulation underlying of the program, so it would make easier for the implementation of this program. Collaboration is also needed in the implementation of all the program, from promotive, preventive, curative, and also rehabilitation, in order to manage the non-communicable disease, which we are going to talk after this. So setiap warga masyarakat Indonesia ini mewujudkan gotong royong dengan saling membantu melalui pembayaran iuran JKN untuk kepentingan kesehatan bersama. Next slide. Now, JKN membership coverage right now, if we see compared to other countries where the range to become universal health coverage is ranged between 12 to 127 years, universal healthcare achievement in Indonesia is actually shows a very significant progress within the 10 years. As of 31st August 2023, the total member of National Health Insurance is around 261 million, or about 94% of the total Indonesian population. This is very nice achievement. And currently, we say there are 25 provinces and 361 cities or municipalities that have registered their people more than 95%, or we call it universal health coverage. So we have 25 provinces and 361 USC province and municipality or city. This is a very good achievement of Indonesia. Next slide. About the healthcare providers, we are already contracted so many healthcare providers all over Indonesia. For the primary health providers, we have 23,592 facilities. As for advanced care, or we call it referral healthcare providers, we have 3,004. And we can see that the number of healthcare providers that is contracted has increased from year to year, and this number is expected to rise in the future, along with our efforts to expand the accessibility of healthcare services for all Indonesian people. Next slide. Health service in the utilization of the JKN program is also increased significantly since the beginning of this program in 2014. As we see in year 2022, the total visit to primary health care has risen up to 205.6 million visits compared to year 2020 in the pandemic era. So we can see, considering this pandemic, there are we have already rise up significantly to this non-pandemic era. Regarding the utilization of hospital, either in outpatient or inpatient visit, is also significantly risen from 69.7 million in 2020 to become 95.9 million in 2022. So it is in year 2022, we can say that the total utilization reached 502.9 million per year, or 1.4 million per day calendar. So it is a very huge utilization in our health facility. Next slide. This is the importance why we should do promotion and prevention. According to Institute for Health Metric and Evaluation data on global burden disease in 2019, the highest risk factor worldwide causing death was hypertension, and it reached 10.85 million deaths a year. And more than 250,000 JKN members are diagnosed with hypertension or diabetes mellitus, new cases each year. So hypertension and diabetes mellitus now are the main contributor of heart failure, kidney failure, and stroke, which cause significant spending in our healthcare spend. And so prevention and promotion is needed to control and prevent complication of this particularly disease. Next slide. In JKN scheme, we do promotive and preventive services comprehensively within 3 levels of prevention. The first is primary prevention. It is for healthy person. We conducted the prevention with health promotion. Health promotion is to encourage a healthy lifestyle behavior through health education, and also giving promotion from media distributed through primary healthcare facilities or public facilities. And we also support the exercise. And the primary prevention is also carried out through a screening. We do screening for health history by filling the questionnaire about medical history of every member of JKN and also their family, to know the risk of diabetes mellitus, hypertension, chronic renal failure, and coronary disease. If the result of this screening of history shows that the participant has the moderate to high risk, then it will be followed to the second prevention or the secondary prevention. But if the result shows the low risk, the participant or the member will be guided to health behavior through health promotion. And besides the health screening, we also conduct the routine immunization as a primary prevention and family planning service, including the contraception and also the education of family planning. For the secondary prevention, it is for the persons with risk. So after we conduct the screening for health history, everyone or every member that has the risk of disease will go through health screening for as mandated by the Health Ministry Regulation number 3 of 2023. We now conduct for 14 health screening, 14 disease of health screening, such as diabetes mellitus, hypertension, anemia, breast cancer, cervical cancer, thalassemia, colorectal cancer, tuberculosis, hepatitis, and congenital hypothyroid. We do this screening through primary facilities and also secondary or referral facilities. So until we know whether this person is diagnosed, is it diagnosed as a sick person or still healthy. When the screening, the secondary screening is result is indicated that the patient have disease, it will follow to the tertiary prevention for sick person. But if the diagnosis is can be underlined as healthy, so they will go to the primary prevention again. For the tertiary prevention, for the sick person, we give integrated disease management program, what we call Prolanis, and also revert back program atau program rujuk balik. So when the person is considered sick, then we can send them to the referral or secondary healthcare facilities to give to do diagnosis and then to give medication. And after they are stabilized in the secondary facilities, they will give back to the primary care for sustaining or maintaining their disease through some programs like Prolanis and Refer Back atau program rujuk balik. So the participant or the member of JKN that is considered sick will be maintained through secondary facilities and primary facilities for the maintenance of the program. And this promotive preventive program is being collaborated by Ministry of Health through their what you call public health services and collaboration with facility of providers of healthcare facilities. So this is a good program, and we do it in the primary healthcare facilities. We do it through capitation and non-capitation program, and in referral or secondary, we do it through INA-CBG's program. Next slide. Concerning the efforts of promotive preventive in primary personal health, the health screening achievement has rose dramatically from year to year. In 2022, we have conducted almost 15,000 screening, but now in 2023, we have already conducted 21.7 million participants. Sorry, in 2022, we have 15 million screenings, but now there's already 21.7 million participants only in 2023. And through these participants, the result of the screening is found 1% risk of diabetes mellitus and 3% of coronary heart disease and 8% of hypertension risk. And from this person with the risk, we conduct the second or we follow up through the second screening. And through the second screening, we can see that from the 1% with the diabetes mellitus risk, we found that 13% is positive diabetes and 25% is pre-diabetes and 62% still normal. And this is also the result of the hypertension screening. From the 8% with the hypertension risk, there are 13% is positive considered hypertension. So with this person with positive disease, we will send them to the specialist in the referral or the secondary health facilities to get medication. And after they were stabilized, they will be maintained in the primary care services also. And from the secondary screening, we can also find about 3% is pap smear positive and 1% lump detected from breast cancer screening. So what we do in the screening from the JKN, we'll discover earlier person with risk or person with disease, so that we can give proper medication promptly within the first stage of the disease. Next slide. And this is for the what we do for the person who already fulfill the screening from the form, health history screening. We give them a WhatsApp blast so they know their risk of disease, and they can follow up by coming into our healthcare facilities to follow up their disease, so they can get prompt treatment and also maintain their healthcare conditions. Next slide. This is the Prolanis, what we said, the chronic disease management program. For the person who has already diagnosed as a chronic disease patient, we give this activity from health consultation, medicine service, laboratory tests, and education, and also physical activities. We do this in the scheme of primary health care, where where the person is registered in the primary healthcare service. So after they got medication from the specialist in the hospital, they can go back to the primary care services to get this activity. So every month we will encourage the members to be to maintain their health status, and also to get medication promptly. So every day they don't get drop out from the medication, and they also have to do laboratory tests independently every month, so they can monitor their healthcare, so their health condition. And they also get education and supporting physical activities to maintain their health condition. And until August 2023, we have this much members that come and visited primary care and get examination and also controlled blood pressure and blood glucose. So by controlling this blood glucose and blood pressure, we hope that they will get a better condition and not going into complication of the disease. Next slide.
Sorry, Miss Lily, you have 5 minutes left.
Oh, my 5 minutes left. Okay. And this is, let me skip this several. This is a referred back program. The referred back program is for 9 diseases, including diabetes mellitus and hypertension. So with this program, we make sure that the member of JKN will get prompt treatment and everyday medication, so they cannot go, or they don't get further complication. Next slide. To support promotion and prevention, we do the online consultation by primary care doctors through mobile JKN application, and we also give telemedicine service for chronic disease patients in remote areas. In remote areas where they cannot come to the facilities in the cities, they can do within the primary care settings in the remote areas, but they can consult the specialist in the city through this medication, this telemedicine scheme. Next slide. We also conduct the iCare JKN, which is what we call medical record of every members of JKN that can be accessed through mobile JKN and through the application of PCare and also VClaim. So the doctors in the hospital can scrutinize what has been given for every patient in the primary care or in the hospital settings. Next slide. Yeah, this is So this with the iCare JKN, every member of the JKN has their own personal medical record that can be accessible by all the doctors that they see. So the medication program of each member can be given accordingly, so that they cannot they don't skip out all the medication that has to be given. The last slide is conclusion. I'm sorry for my voice. I'm not very well right now. As the conclusion, we can say the promotion and prevention in the JKN program is conducted through primary healthcare provider to reduce the prevalence of chronic disease and for better health status. But if necessary, the patient can be referred to the hospital to get specialist examination and also medication. And then after the patient is stabilized, they will be referred back to the primary health care to be maintained by the doctor in the primary health care settings to prevent complication and to maintain their health promotions from healthcare status. The second, promotion and prevention in the JKN program consists personal promotion and prevention health services for healthy, for person with risk, and for person with disease. We have 3 levels of prevention. And the third, BPJS Kesehatan develops digital health service to support the promotion and prevention, even for the person in the remote areas, so that they still have or they still can maintain their health care conditions, even they cannot go to the city for facilities. I think that's what I can say or I can share for our JKN program. I hope this is beneficial for everyone, and we go for the next discussion. Thank you. Wassalamualaikum warahmatullahi wabarakatuh. I give back to the moderator. Thank you.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you for the excellent presentation from Mrs. Lily. Now we will get the discussion section. Maybe I will emphasize some of the presentation of Mrs. Lily. BPJS already implement a program for 5 levels of prevention and also already implement digital health in BPJS. And recently, BPJS also developed iCare that in the future become personal medical record for every citizen in Indonesia. Right now, I will ask the audience in online and offline, is there any question for Mrs. Lily? Is there any question in the online or Zoom? Can admin share the question in the screen? No?
I don't.
Help us.
I don't think there is any questions in the Zoom chat.
Yes, there is a question from participant offline. Please. Mention what's your name from the affiliation?
Oke, thank you, Bu Eni Rama. Mohon maaf pakai bahasa Indonesia. Jadi pada dasarnya matur nuwun Bu Lili atas kesempatannya. Mohon maaf untuk memakai bahasa Indonesia. Tadi kan banyak dipresentasikan terkait dengan program kerjanya dari BPJS Kesehatan itu lebih cenderung ke usaha preventif dan promotif. Nah, itu sebetulnya sudah bagus ya ketika ngomong masalah BPJS itu kan sudah lebih dari 5 tahun berjalan. Kemudian hal yang perlu digarisbawahi adalah usaha preventif dan promotif itu pada dasarnya di FKTP itu sebetulnya sudah berjalan dengan cukup baik. Tetapi kalau kita melihat masalah ke arah prolanis juga, ini seperti pengalaman-pengalaman yang ada di pasien gitu ya. Untuk masalah aware terhadap kesehatan, tadi contohnya masalah yang paling banyak adalah hipertensi dan diabetes mellitus, dan itu memang program kerja di prolanis ke arah situ semua gitu. Mereka datang untuk menjadi prolanis itu ketika pasien itu sudah istilahnya pergi ke rumah sakit. Nah, dengan kondisi-kondisi yang sudah sakit gitu. Jadi tidak ada istilahnya mereka datang ke puskesmas dengan keluhan yang mau screening atau usaha-usaha pengecekan. Itu kan kalau datang ke puskesmas dia hanya mengeluh masalah kok kayak masuk angin ataupun masalah GERD dan sebagainya, mesti mengarahnya ke sana. Nah, akhirnya mereka ketika sudah di rumah terus mengalami kegagalan fungsi, mereka akhirnya pergi ke rumah sakit walaupun tidak hanya lewat UGD, tetapi bisa juga langsung menuju ke mengakses dengan out of pocket, yaitu ke spesialis jantung. Setelah dicek dengan biaya sendiri baru tahu nih, oh ada masalah takikardi ataupun yang lain. Nah, itu yang hal-hal tersebut, masalah-masalah promotion itu menjadi masalah-masalah yang sangat klasik gitu loh di puskesmas yang kurang bisa menembus ke masyarakat ataupun dari pihak BPJS sendiri yang kurang bisa menembus ke masyarakat. Kemudian masalah promotion yang kedua adalah masalah vaksinasi. Nah, masalah vaksinasi itu pun juga menjadi hal yang polemik juga nih. Kenapa? Karena masyarakat mau mengakses vaksinasi masuk ke puskesmas pun juga ada beberapa orang yang ini kan kalau puskesmas melayani vaksinasi hanya di jam-jam tertentu. Nah, akhirnya apa? Mereka yang notabene-nya adalah para pekerja, baik bapak ibunya yang bekerja untuk mengakses vaksinasi ke anaknya, akhirnya ke imunicare ya, ke imunicare, baik itu ke klinik yang menyediakan imunicare ataupun ke rumah sakit yang sudah berafiliasi dengan Bio Farma dan imunicare. Nah, akhirnya apa?
Can you make us simple the question?
Itu juga masalah out of pocket lagi. Jadi apa sih terobosan dari ibu dari pihak BPJS sendiri yang memang ke primary care untuk apa istilahnya hal-hal masalah usaha preventif promotif itu yang bisa mendekatkan ke masyarakat. Begitu aja dari saya, matur nuwun.
Yeah, thank you Mr. Faiz for the question. I think I will collect the question first. I heard that one question from Zoom. Can someone share the question from Zoom? Oh, Zoom or offline? Zoom. Okay. Just a minute. Okay. Please give your question directly to Mrs. Lily.
Oke.
Okay.
Assalamualaikum warahmatullahi wabarakatuh. Perkenalkan, saya Naufal dari mahasiswa Fakultas Kesehatan Universitas Dian Nuswantoro. Izin bertanya. I want to ask about what are the challenge of program Prolanis. Thank you.
Okay.
Okay. Thank you for the question. Mrs. Lily, can we still have one question from the audience?
Okay.
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 Please give a simple, right? Because he has a limited time.
Okay.
Tes. Assalamualaikum warahmatullahi wabarakatuh. Thanks for the opportunity. My name is Alfi from Information and Medical Record and Information Major. The ProLens program is so great, but health seeking behavior of our community in Indonesia is still low. So how to embrace our community to join ProLines, and maybe how to strategy to make our community aware about maintenance their health. Thank you.
Okay, thank you. I think Mrs. Lily, I can combine the question. The first question is talking about what is the innovation of BPJS to make program in preventive and promotion become successful. The second is the challenge of ProLines to become implement in the community. Okay, time is yours.
Thank you. Thank you. Thank you, Pak Faik, Pak Mas Naufal, and Mbak Alfi for the question. The first statement that I would like to say is that is true what Mbak Alfi said, that health-seeking behavior of our community is very low. And that is what Pak Faik also found out, that when we started to make this health history screening throughout Indonesia, at first in 2021, we only reached 2 million people who are willingly doing the health screening, health history screening. And in 2022, we managed to become, to get 15 million people doing this health screening, health history screening. When we were first doing the mandatory screening, so people cannot get health services before they fill the screening test. There is so many objections to that. We have faces many challenges when people cannot access the service before they fulfill the healthcare screening or health history screening. We're facing many objections and challenges, but we're still coming forward. And now in 2023, we're targeting around 30 million people who do the health history screening. And in some facility, we make it mandatory. So people, when they want to come to our clinics or puskesmas, they have to fill out the health history screening before they get access. This is not easy actually, but we must teach, or we must educate our people how to conduct this. And the second, we also give a very massive education throughout media. Nowadays, I always say that BPJS Kesehatan is not only for sick people, but they are also for healthy people who would like to assess their own, or they make self-assessment of their own risk of disease, so they can get an earlier treatment whenever it happens. So we are still trying to do so many ways to encourage people to do the screening of their healthcare. But it is not easy, Pak Faik. I know that people tend to come only when they are sick, and then they go for their out-of-pocket money. But this is our challenge actually. We really give a massive education. We do from social media to give people insight. We also do transformation of quality of JKN. We make sure that every facilities has improved their quality of services, so that the trust of people, of the community to BPJS Kesehatan is also encouraged, increased, I mean. So when the trust of the people is increased to BPJS Kesehatan, I hope they will find BPJS Kesehatan can provide what they need in the health settings, in the healthcare settings. So this is still a challenge, but we hope that by doing this screening of health history, and also the screening of healthcare healthcare laboratory or examination, we can get a better treatment and an earlier decision of giving the prompt treatment. And I hope everyone here or every stakeholders of JKN is also supporting this this movement. Let's do health history screening earlier, at least once a year, and we do it every year, so we can know the potency of disease that we may develop in the future. And Mbak Alfi, this is also one of your duty as a public health community. Yeah, you are going to be a public health practitioner in the field. So you also has the obligation to make people aware of their health, and BPJS Kesehatan is doing the digital transformation is also to to enhance this behavior of a health-seeking behavior. We give them consultation online. You can do it by mobile JKN, and we can also do the telemedicine. If you are in the remote areas, your access to the specialist is limited, we can provide you with the telemedicine. So there is no, we hope that there is no obstacles for our members to get access to health facilities. So in this, with this all movement, we hope that everyone can assess their own health conditions within the early stage. And Mas Naufal, the challenges of program Prolanis is the person or the member that with the disease, if they don't feel it important to come and to join this Prolanis, it's very challenging. But we believe that every primary care facilities that has been contracted with us has the innovation how to get this member to come to Prolanis, because we make some indicators. So for the facility, the primary care facility, we give incentives. We give incentive if they can get this person with diabetes and hypertension controlled, and then this will become their indicators of performance that is related to the amount of the capitation paid for them. So whenever they get more person with controlled diabetes and hypertension, they will get more payment then. So I hope these incentives will give more primary care facilities more lure to get their members more healthy all the time. I think that I hope that answers all your questions. Thank you, Bu Eni.
Thank you, Mrs. Lily, for a great discussion. And for the next section, on behalf of the committee, I would like give appreciation for Mrs. Lily for certificate. Mrs. Lily, can you see our screen?
Okay, thank you.
Thank you again, and I hope you get an excellent meeting for the next season. Thank you very much.
Can I take pictures first?
Okay.
I would like to take these pictures. Thank you.
Thank you.
Okay.
See you next time. See you next collaboration.
Thank you. See you later. Bye.
Bye. Okay. For the next session, we will go to the second speaker. The committee, the speaker is already joined in the Zoom. Okay, I would like to invite Angela Y.M. Leong from Hong Kong Polytechnic University. Can the committee pin the speaker?
Hi, everybody. This is Angela from Hong Kong, from the School of Nursing, the Hong Kong Polytechnic University. And I'm also the president of the Asia Health Literacy Association. Thank you, Amy, to invite me to join this very important international seminar and workshop on public health action. So my great honor to meet everyone via this Zoom.
Okay, Angela, I will share your CV to the audience. Can the committee share the Angela? Angela is a professor and director of WO Collaborating Center for Community Health Service in School of Nursing of Hong Kong Polytechnic University. And she is an active researcher in health literacy and dementia caregiving, and with a wide range of publications in international journals. And she also dedicated to community-based health promotion initiative. She served as executive board member of International Union for Health Promotion and Education, member of World Health Organization Global Network on Long-Term Care, and also WHO Clinical Consortium and Healthy Aging. I think she is an excellent expert for health literacy. So I will give opportunity for Angela Leong to share the presentation. You have 30 minutes. Time is yours.
Okay, thank you. Yeah, let me see the screen first. Yeah. Okay, right. So I can see the screen right now. Okay, thank you. So my great honor to join the seminar. Here I noticed that we have a section called the health literacy role in improving the healthy lives in the era of society 5.0. And this is so interesting that I think the themes fit very well with the knowledge that I have and the experience that I had here. And in this talk, I would like to highlight some of the issues in relation to health literacy by the time when we develop program and evaluate the program. As Amy has mentioned, I've done a lot of work in health literacy, and some of the work are on the Chinese population. So here I'd like to share the experience with you. Next slide, please. Yeah, so the presentation will be divided into two parts. The first part, I would like to show to you the system that I developed 2 years ago at the time when we have COVID. And this is called the Blended Gaming COVID training system, and is tailor-made for the staff in the residential care home. I will talk about how we develop the system and how we deal with the issues of health literacy, and also and some of the evaluation that we have done on this system. Can I just check? Can you hear me clearly?
Yes, I can hear you.
Okay, right. Thank you. And the second part of the talk would be focusing on digital health literacy, which I think everyone is now looking at information from the internet. It is very important to emphasize on the digital health literacy, and I will show you how this digital health literacy is related to psychological well-being. Next slide, please. Okay, so this blended gaming COVID training system, I make it short as a BGCTS, is a system that we develop it in a very structured way. By the time when we have COVID, we all understand that we want people to pay attention to infection control. particularly those people who are working for older people. Sorry, there is a voice over here.
Jadi kan itu absen toh yang
Maybe someone needs to mute the mic.
itu loh. Ada yang nanya, kamu ada yang nanya, kan banyak nanya toh. Terus
Okay, good. So thank you. So now this system is a structured one, and we make it as a standard according to the WHO infection control guidelines, as well as the local guidelines in Hong Kong. So we make it standardized in a way that we want people to use it to understand about the infection control guidelines with a very easy way to do it. So the system is made in an easy to manage one. And we want people, particularly those people who are working in the residential care homes, to recap the principles of infection control very quickly, so that the system is developed for the staff in these residential care homes. We all know that people working in the residential care homes, they are very busy and they do not have a lot of time. So that's why the training is tailor-made for them in a precise manner. That means that we want to let them learn in a short period of time. And at the same time, the time is a quality time for training. So this is the first type of training, I think, in Hong Kong and in the world, that we use game to train people with infection control concept. We understand the staff, they may not have very high level of health literacy, so asking them to understand the lengthy infection control guidelines would be very challenging. So that's why we are addressing their health literacy levels when we develop this system. Next slide, please. So on the right-hand side, you can see this is the guidelines issued by the WHO at the time when we have COVID. They talk about what we should do in the healthcare facilities. And at the same time, we make good use of this structure to develop the system with 8 chapters. Each chapter actually is made according to the 8 posters that WHO issue. So we keep all the data in a highly secure web server, which belongs to my university. Next slide, please. So you can see that on the right-hand side, everyone has to log in when they use the system. Each user would have their own username and password so that they will feel safe that their data are being secured. They can use their mobile phone, no matter it is an iPhone or Android phone, is still okay. They can also use their desktop to use it, or a tablet. Once they log in into the system, they can start their learning progress on their own pace. So whenever they click on the stories or the games, we will keep record of their learning progress. There are words, there are voice over there leading them to learn, so that even though they cannot read the wordings written on the apps, is still okay. So they also notice that there is a progress bar to show that how much they have progressed in their learning. So the key point is that they can get to know and about their own progress, and they can stop at any time when they have to deal with some urgent issues in their workplace. The good things is that when they come back to the system again, when they are free, the game will start at the time when they stop the program. So they do not need to repeat the games again once they have finished that part. Next slide, please. So as I mentioned, there are 8 chapters, and next slide, please. So 8 chapters, I can show to you some of the chapters that we have. The first chapters is basically the introduction and talking about what they do. And the second chapter is talking about how we can manage the patients if they are suspected with the COVID-19 in their care facilities. And so they will highlight what to do and how to deal with the environment cleaning as well. The third story is about protecting themselves from the workplace, so they can choose some PPE, the personal protective equipments for them when they deal with certain procedure. Next slide, please. We also mentioned about the environment, right? So the environment has to be clean with the required infectants. So that's why we highlight how to do it, how to prepare for the infectants. And with the pictures and the voice over there. Next slide, please. So when they talk about managing their own protection, we highlight that what kind of PPE they should choose at different procedures. Next slide, please. Next slide, please. Yeah. Okay. So this one, this is the animation. I hope that you can see it. Because when they have different scenarios, they are asked to choose the PPE. Sometimes the PPEs are available, but they don't know how to choose it. So through this game, they would, based on the scenario, to choose the right PPE that they should have. So there are 5 scenarios that we set up. For example, when they are in the entrance of the residential care home, what kind of PPE they should put up. And by the time when they have some respiratory specimens collection, so they have to choose the right PPE to protect themselves. So I think many of the users of this system really enjoy this kind of game because it is very practical and they feel that they can remember the right things with a short period of time. Next slide, please. Next slide, please. Yeah. So the story 5 is about communication. At the time when we work in the residential care home, the staff should also get to know how to deal with the query from the family members. And also they need to learn about how to explain the situations to the family members. So that's why there are some, again, we use scenarios to let them choose the answers. So based on the answers that they have chosen, the scenarios will keep on changing. So that's why it is called the visual novel-based adventure. This kind of novel-based adventure is interesting because by the time when they choose different response to the questions, the scenario will keep on changing. So the ultimate goal of this kind of scenarios is to train up their communication skills so that they get to know what kind of response that they should provide to the relatives. Next slide, please. Story 6 is about some knowledge about COVID. Here we have set up multiple choices and true or false questions for them to answer. If they can answer it correctly, you can see that in the animation, the nurse can stop the virus to go into the residential care home. We have covered at least 5 areas in all these questions so as to ensure that the staff get to know about the signs and symptoms of COVID, how to clean the environment, how to prepare for the preventive measures, and knowing the means of transmission of the COVID and how they can protect themselves by doing hand and respiratory hygiene properly. So I suppose that if COVID is changed to another topic, these multiple choice questions can be changed to some other topics like normal respiratory infection or like flu, influenza vaccine, influenza infection. These kind of topics could also be converted. Next slide, please. Stories is all about protecting the staff so that they can learn how to deal with the stress. So we use bubbles to show different options for them to choose, and they can drag the bubbles into the lady and showing that the choice that they have made for dealing with the stress. So there are many coping strategies over there. For example, washing hands and smoking, talking to other people. Some of these answers may not be correct. So if they drag the incorrect bubbles, then the heart on the top would decrease the size, and eventually the game will be over. But if they choose the correct strategies to deal with stress, then they will be able to make the ladies happier. So this kinds of response from the system is very important so that the users get to know about the correct coping strategies that they should choose by the time when they have stress. Next slide, please. So I just showed to you that the options that we have over here, some of the options are very tricky, like washing hands cannot be helpful to coping with the strategies, coping with the stress. Next slide, please. So this story is my favorite one. This one actually is talking about the 5 moments for hand hygiene. So we have captured a lot of short videos and asked them to choose which ways of hand washing is the proper way. So if they have chosen it, then a tick will be shown. But if, of course, if they cannot choose the correct method, a cross would be shown. So bringing up these videos to them would give them a lot of impression to show that what kind of proper hand wash should be made. And we also, the next slide, please. We also have some scenarios to show to them that how they could deal with the clients as well. Next slide, please. Yeah, this is the clients that we need to show to them that if they are going to do the dressing for the older people, so what they should do is to clean their hand before they do anything. So this kind of scenario of hand hygiene is shown in a story. So the users can use their mobile phone and touch on the screen to choose to react as if they are dealing with the clients in the workplace. Next slide, please. So by the time when we develop the system, it is very important to involve the users. So we have invited 8 users who are the workers in the residential care home to join us in the development. We conduct cognitive interview to them so as to collect the feedbacks that they have, and sometimes they may have suggestions for us how to develop the system that fits their situations. So by the time when we have the cognitive interview, we actually go through the step one by one and collect their suggestions. So we actually have prompting questions for them and let them look at the graphics that we have designed and ask them to read aloud what they can see, and so as to check out whether our graphics could be easily understood by the staff in the residential care home. So the popping questions are important because that can give us the opportunities to ask the staff how they feel about the system that we have just developed. Based on their comments, we modify the system before we officially launch the system. Next slide, please. We also use a user acceptance test to test out whether the staff of the residential care homes feel this system is user-friendly, and we have used this user system usability scale to ask them to give the rating. If they totally agree the situations, then they would rate 5. If not, they would rate 1. So we have 10 questions asking them. Eventually, the 8 staff who have trial used the system indicate that this system is very useful, is user-friendly, and they give score 5.5 5 out of 7. And the mean score of the usability scale is 67.1 over 100. Next slide, please. So we are quite confident that now we have collected the comments and suggestions made by the staff, and we modify the system, and based on the comments we improve the system a lot, and also improve the presentation formats and the features. And initially we did not put up a voiceover, but eventually we put up the voiceover and ensure that the volume is good enough, even though they are working in the noisy workplace environment. In general, the users describe this system as very informative and motivational for them to learn about infection control practice. They like the animation because they feel that these animations is pretty attractive and interesting, and they found that this kind of learning through games is fun and make them engage into the learning throughout the whole process. Next slide, please. So after the development, we want to find out whether this system is effective or not. So we use a cluster randomized control trial to test out the efficacy of this system on infection control practice. We advise the staff to use 2 weeks to use the system. And within these 2 weeks, they can access the system without limitation. That means that they can use the system at any time they like. And we encourage them to use the system in 15 minutes for 1 chapters, and in each chapters they can spend time for 15 minutes so as to go through all the games. And so in total, since we have 8 chapters, so in total there are about 120-minute learning throughout these 2 weeks. And to support them, we have arranged face-to-face group discussion so that they can clarify the misconcept, and we send a nurse to go to the residential care home to conduct these face-to-face interactive sections. Some of the homes actually would like to do these interactive sections by Zoom, so we do it by Zoom. So in total, there are 30 residential care home units participated in this cluster randomized control trial. A total of 212 workers are involved here in the trial. Next slide, please. So you can see we randomized the residential care home units so that we can have the intervention group and control group. On the left-hand side is the intervention group that eventually 7 residential care homes with 114 staff are involved in the intervention. And on the right-hand side is the control group, 6 residential care homes with 98 staff involved. So at the baseline, everyone completes a survey, and we have sent a research nurse to the homes and conduct observations. These on-site observations is important because we can objectively monitor the infection control practice that is actually happen in the homes. And after the use of the intervention, that means using the system for 2 weeks, we send the nurse to the residential care homes again to do the on-site observation, and we ask the users to fill up the survey again. Next slide, please. So you can see this is the profile of the participants in this randomized control trial, and on the mean age, they are about 47 to 48, and the staff, majority of them are female, and they have a wide range of educational level, but many of them do not have very high education. About majority of them, they have secondary school education level or below. So you can see that as the staff educational level is not high, their health literacy may not be high as well. So we invited the staff from all ranks, including nurses, the therapists, the health workers, the personal care workers, as well as the therapist assistants. So the health care workers, personal care workers, and the therapist assistants, they are not professionals. Their educational level may not be high as well. So their health literacy level would be low. So we have two types of homes in the Hong Kong. So some are government subsidized residential care home and some are privately run by the industry. Next slide, please. So as I mentioned, we have the on-site observation by the research nurse. So by the time when they conduct the observations, we actually blind the nurse. So the nurse would not know whether they are going to the site that have received the training or not. So that is fair to the observations. So you can see that this is the proper hand wash on the top two rows. The intervention group, let's look at the intervention group. Pre, that means that before the intervention, 95% of the staff actually has performed hand wash properly. This is pretty surprising because usually the staff in the residential care home, they do not conduct proper hand wash. Usually it's about 30%, but maybe because of the COVID, at the time when we have the observation, everyone is very concerned about hand wash and hand rub. So we are very happy to see that majority, 95% of the staff actually are performing proper hand wash. And after the intervention, there is not big change, but for the control group, you can see that there are some decline, a slight decline as well. There is no significant difference between the intervention group and the control group. As you can see, the p-value is higher than 0.05. I would explain that here is that because of the COVID pandemic, everyone pay attention. So maybe this measure has already reached the ceiling effect. So that's why it is not surprising that even we have a good training system for them, and yet the escalation of the percentage of the proper hand wash cannot be shown very significantly after use. But for the use of the gloves and the PPE, as I mentioned in the system, we have specially trained up how they can choose the gloves and the PPE. So you can see in the intervention group, there is a significant improvement after the use of the system, while the control group has a significant fall after the use of the system. They fall from 8.4% to 5.4%. So there is a significant difference between the intervention group and the control group. As you can see, the p-value is smaller than 0.01. Next slide, please. So we also asked the participants to report whether they have any improvement in their knowledge as well as their practice. So this is the results of their self-reported infection control practice. That is mostly related to the knowledge that they have. So you can see in the intervention group, before the intervention, the mean is 40.23. After the intervention, there is an increase to 42.81. While the control group, there is a drop from 42 to 41.66. And there is a significant difference between the intervention group and the control group. As you can see, the p-value is pretty small. So that concludes that after the training, the users of the intervention actually will feel that they have significant improvement in their infection control knowledge and practice. Next slide, please. So I would say this system is good in a way that we have addressed the staff health literacy concern, and they do not need to read all those lengthy guidelines, but they can just use the system to play some games, and the learning pace is actually controlled by the staff. That means that they can learn at the time when they are convenient. So this is the good thing about the system. By the time when we develop the system, we pay special attention to the staff concern as well as their health literacy. So we keep on inviting them to give comments to us, and we try to modify the system based on their comments and suggestions. This is good in a way that by the time when they are involved in the development of the system, by the time they use it, they will feel they like the system very much because they are parts of the developers of the system. So we can show this system is good in a way that improves the infection control practice, and particularly the use of the gloves and the PPE. And they also report their increase in the knowledge. Next slide, please. So now I have completed the first part talking about the infection control system. In the subsequent few slides, I just want to highlight a very important message about the digital health literacy. To start with, maybe I should emphasize that the infodemic is one of the issues we notice it right now. Many of us actually look for health information in the internet, but unfortunately, many of the information in the internet are not reliable. Sometimes it was transferred and disseminated with lots of careless mistake. So that could mislead the layman about the true or real information. Particularly those people who have chronic illness or they are older adults, they may not be able to understand the whole picture of the health message, so they would be misled. Next slide, please. So infodemic is a situation that we need to pay attention to, and so we advocate for the correct or the right information that should be disseminated in the internet. Next slide, please. Next slide, please. Yeah. So digital health literacy means that we have to support individuals to build up the capacity to assess and understand, evaluate, and apply the health information from the electronic sources. Electronic sources means it can be internet, it can be WeChat, WhatsApp, Twitters, or some other electronic means. The key issue is that during pandemic, we actually noticed this kind of issues that have significant impact on many people. So WHO actually mentioned that this is not only pandemic, it is actually infodemic. That means that we have to take care of the misled information all around the world. Next slide, please. So to build up the digital health literacy, we have to pay attention to sense of coherence so that we can build up our capacity. So I have done a study which is about sense of coherence and digital health literacy in older people. We have invited older people to complete a survey in Asia, and the participants include people from China, including mainland China, Hong Kong, Macau, and we have invited participants from Philippines and Singapore to join this online survey as well. We invited older people who are aged 60 or above to join this survey. So we use structural equational modeling to test out the relationship. Let me show you the result. Next slide, please. So we use the structural equational modeling to show that the relationship among digital health literacy and anxiety. You can see that the line here, digital health literacy, is directly related to anxieties. You can see the beta here is negative. That means that if a person have higher digital health literacy, their anxiety level would be lower. And digital health literacy is also related to sense of coherence. Sense of coherence means that they are able to feel that the situation, the adverse situations is manageable, and they can comprehend the situation. And that's why they found such an adverse situation could also be meaningful as well. So the sense of coherence is another psychological well-being. If a person has high sense of coherence, they are able to cope with the adverse situation. So in this study, actually, we verify the situation. if a person have a high sense of coherence, their anxiety level will be lower. So as you can see, the beta is negative. We also noticed that in this study, if a person have high digital health literacy, their sense of coherence actually would be higher, and at the same time, they would have lower anxiety. So this study actually verified the hypothesis that we have made. Next slide, please. So next slide, please. Yeah, so I have explained all these important pathway to you that this model, it fits very well. That means that the data actually support the hypothesis that if a person have a high digital health literacy, they have lower anxiety, and the digital health literacy should be further developed and supported so that people would have better psychological well-being. Next slide, please.
Sorry, Angela, you have 3 minutes left.
Okay, right. So I just conclude that this digital health literacy is something that we want to pay attention to. Next slide, please. That I think the government can do a lot of things to support everyone's digital health literacy so as to reduce our anxiety and improve our psychological well-being. Information should be made available so as to support people to have appropriate health decision. Next slide, please. So as a conclusion, we would say digital health literacy is something that we can pay attention to, and at the same time, sense of coherence is something that we could also build up for individuals. Next slide, please. So this is a conclusion. So once we support people with higher digital health literacy, the people will be able to understand the health information in the internet and avoid misinformation and try to reduce the stress during the adverse situation. And I suggest that we could build up more community-based programs for improving everybody's digital health literacy and improve our mental well-being. So that's the conclusion of my talk. Thank you very much. And I think the next slide will show my email. So you are welcome to make suggestions and comments. Thank you.
Thank you, Angela, for very interesting your study. I think it's two study that you have been shared to us. The first one is blended gaming COVID-19 training system. I think it's very interesting because you also share that it's helping evaluate also. So maybe audience have a curiosity about the implementation and so on. And the second is that pandemic also has infodemic. So we should concern about digital health literacy because it will increase anxiety. The next session we will take a question and discussion section. For the audience, I will open the question. Is okay? 1, 2. Okay, the first question, please, committee. The microphone. Please share your name and the affiliation.
Hello, my name is Nurjana. On behalf on committee, I would like to say a big thank you for Angela, for Professor Angela Long, to your sharing to our participant and during your busy, is it in the early morning there? Yeah, thank you very much for your for this opportunity. And my question is, I have two questions. First is about your research in gaming. It's very inspiring intervention by gaming because something funny make people can include to the intervention. I would like to know how to implement in the community because you say this is in the research and the people, the caregiver or nurse control the audience, the respondents. but maybe in the reality in community is maybe different. So is it has been implemented in the community, and how it's run? And my second question is about digital health literacy and anxiety. Yes, it's good if one have a good digital health literacy and the anxiety is lower. But on other hand, if someone worry about the condition, they will try to search information. So I think the worries is good. But how to define the something about worriness? I think feel worry and anxiety. Maybe is it different? And I think it's important to make people worry about the health issue. Thank you, Angela, and good for have a good day, and thank you, and successful for Ahla and your work in health literacy. Thank you.
Thank you for the questions. Yes, we have just finished the study, the research part. So now we are trying to put this system into the community. So I agree with you. It is very challenging to put the research output into the community. So we have to set up a team to do this one, like a team who have to talk to different residential care homes to let them know about this system, and also let them try on that. And hopefully in the future, this system can continuously used by the residential care home. I think the good points of this system is that is automation. It has a good record of the learning process and whether the staff has learned or not. So we try to talk to the boss of all those residential care home so that they can understand this training system can help them to keep a good records of the staff training. And I think this is a best practice. Knowing that the staff are well trained or not, I think this is the responsibility of the boss. And at the same time, we also lobby the government as well. We are lobbying the government to adopt this kind of online training system as a usual practice. I think it takes some time, but at the same time, we are hopeful that this is not only restricted to the residential care home. We expect that this system can be used in the nursing school as well, because many of the nursing students actually need to know about infection control practice. So that would be a good system for the nursing school to use it to train up the nursing students. Yeah, maybe next year I can come back and tell you whether we are successful to put into the community. We are trying very hard on that. The other answer about anxiety and stressful events, yes, I agree with you that sometimes when we are worried about the situations, we will look for information from the internet. But having said that, if we worry about the situations, we would not go to that far extreme that they have some anxiety. Here, anxiety, I actually refer to the very extreme situations that they have some kind of like disorder, anxiety on the future. So this is a kind of a psychological discomfort to the individuals. So basic worry about situations leading to the people to find information, I think this is a good point. But we don't want to see people to go to that far that they have anxiety. Anxiety would be some kind of disorder. So we actually find that those people who have high ability to look for health information in the internet actually can have less anxiety. That means that they worry, but they would not go to that anxiety level. So I think the good points about digital health literacy as well as sense of coherence is that this is individuals' capacity. We can change our capacity through training and public education. So that's why I think this is something that we can work together to improve everyone's digital health literacy and sense of coherence.
Okay, thank you, Angela. Maybe I will make a resume that Nurchana try to know how to implement the CAME. I think is the next step is we talking about implementation science, right? That
Yes.
How we including the digital health in the real world without controlling the respondent. I think it's the next step. The second, that's you mentioned that if we have high digital health literacy, maybe people will confidence to seek information in the internet, so the anxiety will be low. That's not only worry, but they will try to find the reliable information. And that's our conclusion. Maybe I will open the second question. Okay. This. Please share your name and the affiliation.
Okay, hello, my name is Siva. I'm from Medical Record and Healthy Information. Thank you for sharing, Miss Angela. I have a question. In our community still have a lot of hoax or misinformation about health. They tend to agree with the wrong information and don't want to seek for the right information. So, how to tackle this challenge in our community? Thank you.
Thank you for your question. Yeah, actually we have digital health literacy training. We are now conducting that kind of training in Hong Kong. We use Facebook and as well as some interactive activities to train up people digital health literacy. In a way that we have to spend time with the participants so as to ratify their misconception about the information. And we have some guidelines to them so that they can identify which type of information is reliable. And for example, if we look at the websites that have not been updated recently, or the website is not developed by authoritative bodies, then that we need to train up the participants to have a critical thinking, critically evaluate whether that kind of information on those websites are reliable. So this kind of training needs a lot of communications with the participants. So now we are having this intervention in Hong Kong, and that intervention lasts for 8 weeks. And continuously, we have posted up different materials for them and let them raise questions, and we try to answer their queries by a nurse so that they can have thorough understanding which information is reliable. So there are some strict rules, but of course the strict rules may not be adopted easily by the layman, but through the education, we hope that the lay people could also understand about all these rules. Yeah.
Okay, thank you, Angela. I think I will resume that you implement the digital health literacy training in the Hong Kong to improve the digital health literacy. Maybe in the near future, I will learn from you how to conduct digital health literacy training, because my research is also digital health literacy. Okay, thank you. Maybe we will ask from the Zoom audience. Are there any questions? Okay. Yes, please.
Okay, thank you for the opportunity. First, my name is Rika Junior Amalia. I have one question. Maybe my question is a little bit out of the material, maybe. And my question is, during the pandemic, we used a mask, we washed our hands, and we do a social distancing. But not anymore. For example, washing hand is one of the behavior that must be maintained. So, how do propose people to maintain health behavior? Thank you.
Thank you. Thank you for your question. It's a very important questions here. Yes, by the time when we have COVID, we have a lot of strict restrictions, social distancing, hand washing like that. But I would say COVID, although we try to retain our normal life, but COVID has not gone. COVID is keep going. Every day we have many cases still have COVID. But the issue is that the COVID has not tremendously affects the persons into the worst situations, and that is something that we have to acknowledge that. So since COVID is still here, our hand wash should maintain, and some of the precautions should still maintain, like in the densely populated situations, we still encourage people to wear masks. I can see that wearing masks is a way to protect ourselves as well. So we have to educate our general public to get to know about how to protect ourselves. And of course, the government may not be put a strict rules saying that you have to wash hands how many times a day, and yet general public should be educated, should get to know about what is the best thing to do. So this is again like a health literacy issues. Health literacy is all about information that we get, how much we understood about that, and how we finally make our health decision. So when we talk about health literacy, it's all about informed. So the informed decision means that the information should be given to the general public in a correct manner. So we keep on giving information to the general public that they should hand wash, they should do their hand wash as appropriate, and this is the decision that they should make by themselves. So that's why I would say, yes, health literacy is a very important component in our public education, and we should continue to work on this health literacy. Yeah. I hope I answered your question.
Thank you for the answer, Miss Angela.
Okay, thank you. I think time is up. Thank you, Angela, for your excellent presentation and great discussion. On the behalf of the committee, we would like to give you appreciation as a speaker certificate.
Thank you. Thank you.
Okay. Thank you very much, and thank you for collaboration in Asia Health Literacy. I hope in the next future we can continue to make another conference and also collaboration. Okay, thank you, Angela. See you next time. See you.
Thank you. Thank you. See you.
Oke, alhamdulillahirobbilalamin. Kita sudah memasuki sesi ketiga ini, mau saya ganti bahasa Indonesia ya. Komite bisa membuat gerakan dulu nih kayaknya. I think the audience is already tired. Mrs. Kismi, give some break, some. She is the expert for. Please lead the audience to.
Okay, thank you, Miss Niramani. Yeah, I got a prank. Yeah. Okay, ladies and gentlemen here, would you like to stand up, please? We will, we will stretch. The crew of TVKU, do you have Mau Mere song? Okay, we will wait. Yeah. Before,
because we have honorous speaker in the press promotion, so I implement physical activities.
Before the Maumere song is ready, or maybe we will see the time. Yeah. Please. Ya, please menghadap ke kanan. Ya, move your body to the right. Oh, you the left side. Okay. And then, place your body near your friend in front of you. Ya, dekatkan tubuhnya. Ya, near your body to your friend in front of you. Yeah, if I say rainy, you can massage your friend. Yeah, slowly. Yeah, we will try. Rainy. Yeah. Yeah, feel your friend massage. Yeah. And if I say storm, please add your pressure. Yeah, storm. Yeah, increase your pressure. Yeah, rainy. Yeah, slow massage. Storm. Yeah. Rainy. Storm. Okay, enough. And then move your body back. And yeah. Rainy. Storm. Yeah. Enjoy your friend massage. Rainy. I will join with you. Rainy. Storm. Yeah. Okay. Do you need an hour massage? Okay, enough. Thank you very much. And yeah, have a seat, please. I'm sorry, we have a limit time because Mr. Anung will go to Sragen after this. Miss Rahma, time is yours.
Okay, thank you for Mrs. Kismi that follow my improvisation. Okay, I will invite the third speaker that is very famous with the health promotion. So I encourage all of the participants to make a healthy action with physical activity. Please come to the stage, Dr. Anung. Dr. Anung Sugihantono MKes. Please, committee can share the CV. Oh, okay. CV of Mr. Anung. Okay. Mr. Anung is the chairman of Provincial Committee of Indonesian Society for Health Promotion Education. He was a former Director General of Disease Prevention and Control Disease Ministry of Health of Indonesia. He is a lecturer at Health Polytechnic Ministry of Health Semarang and also Faculty of Public Health Universitas Diponegoro Semarang. He is now health officer in JISA, Japan International Cooperation Agency, and also Department of Foreign Affairs and Trade Australia Indonesia Health Security Partnership. I think he is a very excellent speaker to share their knowledge about health promotion in Indonesia. Please, the state and time yours, Mr. Anung, you have 30 minutes.
Thank you, moderator. Assalamualaikum warahmatullahi wabarakatuh. Good morning, ladies and gentlemen. Hope you all are in a good health today. Excellencies, Dean, Program Manager, fellow speakers, and also moderator, participant both online and also offline. Alhamdulillah, in this morning, we able to meet in a good health following the entire series of 4th International Seminar and Workshop on Public Health Action 2023. In partnership with the hosted by Faculty of Health Science, Dian Nuswantoro University, in partnership with many universities in Indonesia and also in abroad. I received assignment to deliver the material or paper. The theme is behavior change strategy to promote healthy lifestyle in era of the society 5.0. Indeed, in this an interesting and challenging matter in dealing with current and future condition in society. When we are talking society, we as a part of the society and also we as a part of the community. However, I take this setting in Indonesia, especially in Central Java, when we are talking about the society 5.0. So in this seminar, I would like to say again thank you for the Faculty of the Health Science Udinus, student and fellow audience that we have a great opportunity to share knowledge and also experience during this seminar. For the beginning, I would like to use an outline of my presentation as a follow. What is the society 5.0? And then the second one, what is the health behavior in terms of the theoretical, and then behavior change in health sector, so that people can still make healthy and productive. And way forward, kind of resources we need to address all of things that society 5.0 is a part of our life and the next future. For the first topic, when we are talking about the 5.0 society, I will give you information according to the historical of the Industrial Revolution. This means it's not only talking about the timeline of the Industrial Revolution. We are talking about the changing the behavior from man to at the first time until right now. When we have Industrial Revolution 1.0 occurred in England at that time, the end of the 18th century, that the Industrial Revolution 1.0 is marked by a safe of use of the labor. It means that previously we are using animal and human power, and this was later replaced by machine-based manufacturing. The discovery of steam engine in 18th century was used to produce goods marked the Industrial Revolution. The British used the steam engine to increase productivity of the textile industry by using the mechanical loom. Industrial Revolution 1.0 made Europe able to send warship to all of the country in the world at that time. And the impact of that is the environment polluted by two steam engine and other factory waste. It means we are talking about the environment influence of the behavior in that time. The second one, Industrial Revolution 2.0, occurred in the last of the 19th century until beginning 20th century. The system changed also as the technological revolution. It means that the Industrial Revolution 2.0 was marked by the discovery of the electric power. Car began the mass produce, and the problem of time, constraint of purpose of the start to finish resolved by production line. Revolution emerged which utilized conveyor belt. So the skill of the person is not all of the activity only one person, but now specialized and also only working at that area. Industrial Revolution 3.0 is a system change to previous using mechanical technology, changing to the digital technology. The Industrial Revolution, which often referred as a digital revolution, occurred from 1980 until now. Humans still have an important role in the producing goods until the Industrial Revolution 2.0. This change after the Industrial Revolution 3.0, the information age began with the emergence of the machine and could move to think themselves, namely robot and computer. And that time, we have increased also the case of diseases when we are talking about the using the computer and robot. Fourth, the Industrial Revolution 4.0 became popular since Klaus Schwab released the article 2015. This mark changed the industrial system from the digital to automation. Although the entities in it to community and using internet technology. The characteristic of the Industrial Revolution 4.0 are characterized by various applied of this technology, such as advanced robotics, artificial intelligence, Internet of Things, virtual reality, additive manufacturing, and also distributed manufacturing. Now we have anxiety also with this situation because there are many messages, or it's not only talking about the message itself, but talking about the we call flooding of the message. Revolution 4.0 has quite impact of the human life. Overall, it is able to change production pattern and business model in various industrial sectors. Many activities such as work and human waste or lifestyle have changed to become a practical because the use of automation system to carry out their activities. This convenience encourages the achievement of the new value creation. We also have a possibility or opportunity to increase the creativities and also innovation. Now, talking about the Society 5.0. Firstly, initiated by Japan, the idea behind of these issues, although the traditional knowledge and modern-based knowledge, such as AI, robotic, Internet of Things, to fulfill the human need. In a simple term, we use resources for human to live comfortability. Society 5.0 itself was just initiated 4 years ago and was created a resolution that the industrial concept and industrial society do not have much difference. but concept of the society focus on more human context. Society 5.0 use modern technology, but only rely on human as its main component. Society 5.0 is an era where all technology is a part of human themselves. Now we also have a challenge or also have an anxiety when we miss mobile phone, when we miss access of the Wi-Fi and so on and so on. So the society 5.0, the main component is human, who can create the new value through technological development, which can minimize gap in human and economic problem in the future. Colleagues and participants, understanding the comprehending technological development of course, it will be interesting what has happened and happening in the Industrial Revolution 4.0, also implication of the health services throughout the world. Some example in high-tech health services include 3D diagnostic tool, health services robot, which has been widely used in COVID situation, genomic technology, also very familiar in the COVID situation, which able to diagnose microorganism or virus. It is used to determine drug sensitivities more accurately, more quickly and accurately. The other one, we have telemedicine as an implementation of 4.0 revolution. It's from implementing society in the health sector. The telemedicine application is defined as long-distance health services that allow people to carry out online consultation with the doctors and other health experts without having to go directly to the health services location. Have cluster regulatory interspace short palindrome PIT, CRISPR. CRISPR as a part of the technology that we can use to various target of the gene in human, bacteria and so on. So that's why more easier for us to understanding who will be have diabetic, for instance, who will be have a cancer after we analyze the gene from the human side. In the future, they will be used synthetic biology, functional genome screening, transcription modulation, and the gene therapy. This is more expand when we are talking about the therapy after we have a stem cell at that time. Furthermore, the silico computing tool have helped to search for the new drug by developing small molecule for the more than 3 decades and a very effective strategy to developing new drugs. You know, we have experience developing vaccine during COVID. Usually, when we are talking about vaccine, almost 3 until 5 years developing vaccine. But during COVID, we used all of the technology as a part of the revolution technology 4.0. We only need 1 year to develop the new vaccine, especially for COVID. Over the last decade, there has been increased computation method of the drug discovery, such as molecular docking, pharma-4 modeling and mapping, de novo design, molecular similarity, calculation, and protein sequence-based virtual screening. However, time has gone, very sophisticated in silico computing technology is needed, and finally, the high-through screening process emerged, which was based on the more sophisticated in silico program and very capable computer. What I want to say when we are talking about the industrial revolution, The implication for health services also leave various challenges related to human behavior as the subject of the change and increasing technology development. Ladies and gentlemen, participants, the second topic I would say the health behavior. Understanding the health behavior should be addressed to core with the human behavior. Human behavior, its mean is a response from the stimuli or to the stimuli. Behavior can be visible, we call overt behavior, or invisible, we call covert behavior, such as person knowledge, attitude, behavior. And behavior is very complex. Many factors influence a person's behavior. Health behavior has three different forms, such as and practice. And we have also three domains: cognitive, affective, and psychomotor. According to the Noto Atmojo said that behavior in a person respond to stimuli or object related to illness and diseases, the health services system, food and drink, and the environment. When I'm talking the environment, please consider that the environment is not mean physical and also biological itself. We are talking the environment about the technology, about the habit in the society as a part of the environment. In the context of the health services, health behavior is divided into two: behavior to the people who are served or receive services, and behavior to the service provider or health worker who serve. And according to the Skinner, we have three groups of the health behavior, namely health maintenance behavior, as a person behavior or effort to maintain the health so as not to get sick, and effort to cure illness. Health maintenance behavior consists of three aspects: behavior to prevent the disease, health improvement the behavior, and nutritional behavior. Health seeking behavior concern a person effort or action when suffering or an accident. Environmental health behavior, a person respond managing the environmental condition as an important thing that can influence health status. The physical and social cultural environment can influence a person's health. For example, how the person manages access disposal, drinking water, and also using the technology and others as a part of the environmental health behavior. Behavior, one of the ways influenced by environmental condition and the nature of human adaptation, will be directly or indirectly influence individual healthy life living behavior or even the community behavior. This change in behavior can be lasting or permanent or momentary like COVID due to the demand the situation. As one of the question previously, in this case we learn of COVID pandemic situation. The behavior using washing hand and also wearing the mask, it's no longer behavior. Even all of the people understanding that there is quite severe air population around us in this time. The use of technology, software or hardware, to run this technology, the use of Zoom, webinar, in various activities, for example, will affect people relationship with each or other with many results. And decline the social relation or even the community social capital. So, the Industrial Revolution 4.0, even 5.0, on the other hand, will make easier and pamper the public getting health services and health provider give services, but on the other hand, it is also possible to raise the new behavior in society that is less beneficial in realizing the person's level of the health. Another interesting thing, it is implementation of the Society 5.0 will be dominated by the who have no technology from start, or we call Generation Z. Those born after 20, physiological characteristic those generation are currently now is 20 until 25, have life expectancy longer than us, in line with the improvement of the health services in last 30 years. The question is what we do to that situation? We are waiting this era will be direct us, or we will be drive in this era. So the third topic when we are talking about the behavior change and society preparation to become part of the Society 5.0, we are talking about the factors play an important role in changing behavior, experience, belief, social culture, economic, adequate health facilities. That is a factor that not influence single, but they are influence each other to make the health status of the person or the community. The determinant factors of the health behavior are factors that determine to shape a person to carry out the health behavior and appropriate to the place. There is 3 theories regarding the determinant health behavior according to the expert, namely Lawrence Green, Seanduskar, and WHO. There are many of you are very familiar about that one. Lawrence Green talking about the determinant of that behavior is predisposing factors, enabling and also reinforcing, and supporting factor or predisposing factor as a habit, culture, response, knowledge, traditional value, and also attitude. Can we change with the Society 5.0? Yeah. There are no letters just only sent by computer and so on. That is a part of that. Enabling factor include fulfillment of the required health environment and facilities. And the driving factor or reinforcing factor include the health worker in the form of the behavior or attitude they carry out of the influence of provide an example to the public. According to the Sehandukar, determinant of the health behavior divide into the 5: intention or desire, support from those around, availability of facilities, individual freedom or autonomous to make a decision, and existence the situation. Also identify there are determinant of the health behavior, the behavior change is thought and feeling, existence of the someone who is respected, and also availability of the adequate resources or facilities, and the existence of the culture. Indonesia maybe, it's not maybe, actually different with Hong Kong, with others that you have learned to developing such as digital literacy and so on and so on. We have diversity. It's not only talking in Java Island, but we also talking in the eastern part of Indonesia at that time. The meanwhile, several behavior change theories are known, and each of behavioral change theory model focus on different factors. Learning theory, social cognitive theories, theories of reason action and planned behavior, trans-theoretical model of the behavior change, health action and process approach, and the new one is BG-FOG, model behavior change. Digital literacy also part of that. Yeah. According to the social learning theory, that now we more familiar with the social cognitive theory, behavior change is determined by the environmental, personal, and behavior element. Social environment is very strong influence the behavior change in the person and the community. In my opinion, Society 5.0 enables the human to spend more time to planning and strategic tasks. Industry 4.0 will be significantly increase manufacturing and efficiency and created versatility between human, machine, and enabling responsibility for interaction and constant monitoring activities. Industry 5.0 in the future, evolution designed to harness the creativity of human experts working together with efficient, intelligent, and accurate machine. Fundamental change in technology will be in line, or more precisely will be accompany change in human behavior. Including in the health sector, it is seen that the several currently known theories of behavior change will be undergo a redefinition of the factor written in relation to changing environment. Although the state entrance theoretical models such as pre-contemplation, contemplation, preparation for action, action and maintenance will be still applied, or any belief to still be able to use and the model behavior change in the era of Society 5.0. In daily practical life, the habit using technology will still have two sides, namely benefit for the health behavior that are beneficial for health, such as correct diagnosis and early stage to create opportunity for earlier intervention, so the people will be healthier in the future. And the other one, they will be ignore some of the habit, both things that they must be realized as a physical activities, social relation, and maybe will be make a person anxiety and more stress. Dear fellow participants, the final in these resources we need to address all of those things above. I would like to convey that the Industrial Revolution has implication for the way people live and society, which is the necessary today in real world. Learn from the history and experience that we have just faced together, such as COVID-19, to be able to survive, being part of the behavior change and also becoming the part of the new era requirement at least three competencies: creativity, thinking, and critical thinking, also communication and collaboration. The society and community should be encouraged to be a critical, reason, and have a problem-solving skill as individual and or team. It is also collective study. It is not only responsible for one or two institutions. That is the collective duty: educator, student, bureaucrat or policymaker, professional organization such as ISPHA, to continue educate the people to become user of the technological advance, but encouraging innovation and creativity that it is firm, but based on the diverse locality and determinant like Indonesia today. Before finish my keynote speech, allow me to encourage all of us. We are a player. We are not a witness. We are a player of the Society 5.0. That's why we have to more communicate each other to minimize unhealthy lifestyle among our generation. We have to prepare and develop developing healthy policies among the community. We as academia, student, professional organization making collaboration to advocate policymakers to preparing it, and we more focus on the gene set that they make role and make more responsibility in their life in the future. That is all our presentation or our keynote speech today. Hope we learn something from my speech and encourage to build a better society for the future. Thank you. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Please give a big applause for Dr. Anung. Okay, thank you for interesting the presentation. Maybe I will make a summarize that society for 5.0 is we could use our resources for human to be life comfortable. So society 5.0 it has a positive and negative impact. The positive is that a better health service using technology. The negative is because we live in comfortable, we have a bad habit. We have minimal physical activity. We minimal social relation. And maybe we have mental health because we often have anxiety in using social media. For the society 5.0, we should have creativity, critical thinking, communication, and also collaboration. That's my summarize for Dr. Anung presentation. Okay, let's move to the next session. We'll open the question for this offline audience in this building. Okay, one, please share your name and your affiliation.
Okay. Assalamualaikum warahmatullahi wabarakatuh. Thanks Dr. Anung for the presentation. Good morning, my name is Nida Sila Rahma from Faculty of Health Science, Dian Nuswantoro University. So that is interesting that nowadays we live side by side with technology. It was such a great help for our lives, but sometimes nowadays we really more technology too, and sometimes it's not good for our health. For example, in daily life, we like to order transportation online because it's more convenient than walking. So what your opinions about that? Thank you.
Okay, maybe I will collect the question first. Another question? Is there any question in the Zoom? Zoom, okay. Please, the committee share for the participant. Okay, please. Ada.
Thanks, Dr. Anung, for the material. I agree that health behavior is important. Now we encounter another challenge, that is environmental health behavior. We know that the pollution condition in our country is getting worse, and I think it needs changes in environmental health behavior. What do you think about this challenge, sir? Thank you.
Okay, you. Can you repeat the question for the last sentence?
Oh, okay. That is environmental in our country is getting worse. and I think it needs changing in environmental health behavior. So what do you think about this challenge? Thank you.
Dr. Anung, did you get the question? Okay, please, time is yours.
So, thank you, Rahma. So that is why when I'm talking about the challenge and also opportunity when we are talking using the technology. So yeah, that is very interesting actually when we are talking. We now have a telemedicine. We can consult with the medical doctor or the health worker directly from your home or your office, talking about that one. But we lost the opportunity to walk, yeah, from one office to others and relation between one and another. So that's why we now, in terms of, it's not only talking about the technology for the health, yeah. We also make the policies and also what we call the social engineering. We make some kind like we have a bus rapid transit that not all of the person can be use the bus without walking to the others, to the special place that the bus will be stopped there. So that's why we need now make others policies. Yeah. For instance, when we are using the computer after 2 hours or 3 hours or 4 hours, we have to go to another place, yeah, to make it the relax of the our eyes and so on. So now we also, maybe you have a chance also to look, yeah, that how many students in the first grade have a problem with eyes during pandemic and now, because of all of us using the computer for the daily life. That is the challenge. And the policies of that to developing more healthy behavior is needed in the next future. And the second question, yeah, I'm rather confused according to the environmental health or mental health after we are talking about the technology 5.0 or 5.0. So as I mentioned, there are a lot of information now we can get it easier using the others, the computer and also mobile phone and others. So almost not any barrier of the information throughout the community directly. It is hope or misinterpretation in one and another because we have a different level of that. That is also the challenge. Yesterday we are talking about the e-commerce. Yesterday President invite all of the player talking about that one. Because Pasar Tanah Abang is still make a close, yeah, and others and so on. So we will be restricted some of the activities in that situation. Maybe part of that is not talking about the trade and industry maybe, yeah. We are talking also about the how to make it the community, all of the community are happy because sometimes we have benefit, but sometimes we have a challenge about that one. If you go to the eastern part of Indonesia without any internet, Wi-Fi, access of the Wi-Fi, that is very difficult talking about this technology. So Indonesia is very diverse. So that is why I'm talking about the locality is needed in Indonesia policy for the next future, implementing the revolution or society 5.0 in Indonesia. Thank you.
Thank you, Dr. Anur, for the answer. I think I will make resume that Social 5.0 needs social engineering to produce health habit. Dr. Anung mentioned that we will minimal physical activity. And the second, that main information that Angela also shared before is that infodemic can make a disorder in mental health, because many information in the internet, there is no filter or no barrier, so maybe it make some negative impact in the community. That's a conclusion for 2 questions. Is there any another question? Okay, please.
Assalamualaikum, Pak Anung. I'm Dian, one of the lecturer in health faculty. Okay, as I know that there is a connection between behavior, habit, and culture, then if we talk about the public transportation, and then you know that somehow habits to become not easy to change if the habits is become culture. That's happened in our country. That and then we couldn't blame somebody who said, oh, that is my habit. Oh, that is a culture of people in my country. So I don't want to walk because the pedestrians is not support for us to walk. And then we also sometimes blame our climate. So environment is also involved to the situation that make whatever we do, then look, okay, you can do it. So if I would like to ask you, in which part we have to change first, whether in behavior or habit, and then for more advanced, we'll change also our culture. So which part we can do easily? Okay, thank you.
Thank you, Bu. We cannot divide into the scenario to change just only for habit first, or we can change the culture. When we are talking about using mobile phone sometimes, yes, when we have a COVID pandemic, that is mean habit or culture. The more activities are using by phone, yeah, that is maybe we are not talking about the culture, because when we are using term the culture, it's mean traditionally the activities or the habit in that area, and then we can develop step by step to change to the best habit and also best the behavior at that area. But maybe when we are talking in terms of the using the technology such as Society 5.0 or Revolution Industry 4.0, we are talking both together. But when we are talking about the Indonesia, I think, and in my opinion, we cannot doing separately change the habit in all of the part of Indonesia, or change the culture all of the part of Indonesia. We have locally and gradually to change, yeah, based on the knowledge, perception, motivation, and also facility. Because when we are talking about the change the behavior, it's mean also ability to use the facility and the motivation to do like this one.
But culture is also have an important role.
Yes.
In the change of the habits.
Yes, agree.
So that's why somehow we can do for the first step, evaluate again our culture based on the local wisdom maybe.
Yeah, gradually maybe we need like this one, yeah, to change gradually. When we are talking about the some kind like what we call Lebaran in Indonesia at that time, yeah, that is the culture to make relationship one and another. But when we have COVID, yeah, we use the other mechanism without any talking about we will be changed the culture to have a relation. So that's why the behavior and culture is not separately part of the intervention, but we do hope all of the activities are related one and another to do like this one.
Okay, thank you. Maybe more discussion to you. Regarding on my way now to learn more about the social approach. Thank you, Pak Anung.
Thank you, Mrs. Dian. Maybe I will conclude the question that we cannot separate to change behavior between behavior and culture. We should make comprehensive approach because Indonesia has diversity, so we should act local and gradually change the behavior. Okay, I think time is up. Maybe the MC will announce about giving certificate to our excellent speaker.
Yeah, thank you, Ms. Annie, for the lively discussion today. So we invite you over to the stage. Ladies and gentlemen, we will give a plaque and certificate for our speakers and moderators. So we would like to invite Dr. Nurjana SKM MKes to submit the plaque and certificate. Yeah, this plaque is a form of our thanks and appreciation for today's speaker, Dr. Anung Sugihantono MKes. Yeah, ladies and gentlemen, please give applause for Dr. Anung. And then, this is a certificate. Same for Dr. Anung Sugihantono MKes. And then this is a certificate for moderator, for Miss Annie. Yeah, there is a certificate that we give for moderator because get it us, the plenary session, in these two. Yeah, thank you very much. Miss Annie, thank you. And Miss Nurjana. Stay with me, yes. Don't leave me alone. Maksudnya like a crocodile. Don't leave me alone gitu. Temenin aku begitu ya. So ladies and gentlemen, next our agenda is announcement to the winners like that. So this. Okay. We will continue to the plenary session. Miss Annie?
Yes, we still have another session. Okay. Sorry for disappointed you.
Okay. Miss Annie, time is yours.
Okay, ladies and gentlemen, we still have one speaker left. There is Christine Sorensen. Please, committee can share the CV. We have a great expert experience in health literacy, Christine Sorensen. She is an executive advisor on health literacy with a background in public health and global diplomacy. She empowers leaders to improve health literacy by design. She works with public and private sector, as well as academy and civic society to develop health literacy for all. She has been collaborated with WHO, Council of Europe's government, McKinsey, and others. Christine Sorensen was honorary professor in ISU University in Taiwan and the first president of International Health Literacy Association, and also chair of Health Literacy Europe and advisor to the Asian Health Literacy Association. I think she is the expert and excellent for reference in health literacy research. Because right now she cannot join us because she is still in the flight to the Austria. So maybe we can wait for the video from Christine Sorensen. The committee, can you share the video?
Hello, my name is Christine Sorensen. I'm president of International Health Literacy Association, and I look forward to present to you today. I'm sorry I can't be in Indonesia in person, but I hope you are enjoying your conference. I'm calling in from Aarhus in Denmark. It's at the end of the rainbow here, as you can see. It's our local art museum, and I hope you will come and visit one day and walk the rainbow yourselves. I have different titles and capacities, but basically my aim is to empower leaders to improve health literacy by design. And I work with companies, organizations, universities, NGOs, and governments to improve health literacy for all. And you can find much more about me and myself, my activities on LinkedIn, and you're welcome to subscribe to the newsletter called Health Literacy Matters. One of the tasks I love to do is teaching at universities, and this summer I met with international students in Maastricht, at Maastricht University in the Netherlands, where we're teaching health literacy as part of life skills. And what I always learn when meeting with students and colleagues from around the world is how important it is to promote health and well-being of people where they live, love, dream, work, vote, and play, or try to survive during, for example, poverty, war, and disasters. I always had a keen interest in developing the potential of people, and meeting international colleagues like yourself from all over the world helps me to keep me focused and try to invest in the best that we have, namely health. Health is not an end in itself, but it's a means to quality of life. So what is health literacy and why is it important? Well, health literacy develops during the life course. So from very early on, even before we are born, our parents, our mothers are taught about health and how to keep the baby healthy and safe. And then when you are born, the 1,000 first days counts, and later in early childhood, we learn to brush teeth, wear bicycle helmets, and as young people, we learn to avoid risks like alcohol and sweets and drugs and so on. And during adulthood, we try to have a healthy work-life balance, and as elderly, we try to enhance a healthy, active living. So when we're ill, we have to learn about new diseases like cancer or diabetes literacy. So health literacy develops over the life course, and this is what I try to illustrate with this picture. Many ask, what's the difference between health literacy and health education? And to me, health education is all the formal, informal, non-formal activities that are linked to pursuing knowledge and motivation and skills, whereas you can then see health literacy as an outcome of all these learning experiences and the knowledge, motivation, and skills that makes you able to act. So it empowers you and enables you to manage health as part of everyday life. And we know from our research that health literacy helps saving time, cost, and lives. It avoids people getting lost in healthcare settings and healthcare systems. We know that health literacy respects that no one size fits all. It's part of people-centered health, patient-centered health, and shared decision-making because it helps build trust. It strengthens knowledge, attitudes, and competencies, and it does it in all the dimensions of health that you can think of. So, for example, physical, social, and mental health, but also emotional, spiritual, sexual, financial, and digital health. And health literacy is relevant across the life spectrum here, from protecting lives, treating health and trying to cure and care, preventing illnesses, staying healthy through the health promotion, taking care of yourself and your loved ones as part of self-care, and eventually also investing in well-being of people and the planet. And when we look at literacy as part of the concept of health and literacy, literacy is about creating awareness, it's about building knowledge, it's about strengthening competency, being proficient, and eventually an expert in your own health. And we know from a lot of patients that they are experts in their own disease because they live with it 24/7, 365 days a year. So boiling it all down, health literacy can be defined as a way that concerns the knowledge and motivation and competencies to access, understand, appraise and apply information in everyday life to form judgment and make decisions regarding healthcare, disease prevention and health promotion to maintain and promote quality of life during the life course. So you see here, health is not knowledge alone. It's really alone. It's the competencies to find and understand and judge and use information to take decisions when you're ill, when you're at risk, and when you try to stay healthy. And it's not an end in itself. It's really about promoting quality of life, and it changes during the life course. So why is it important? It's because we know that health literacy influences health service use, health service cost, the way people engage in healthcare, the way their health behavior is, and eventually their outcomes, but also equity and sustainability. And we know it's influenced by personal factors, situational factors, and larger environmental factors. And again, you can see here in the model that it changes over the life course, and that we can look at health literacy from an individual as well as a population level. A famous model or a famous approach is from Nadim, and he said that you can look at health literacy from 3 levels: functional health literacy, interactive health literacy, and critical health literacy. And functional health literacy make you aware of what is health and why does it matter. And interactive health literacy makes you able to engage with health professionals and other stakeholders involved in health. And critical health literacy makes you able to do problem solving, engage in wider societal aspects of health. And eventually, when all this comes together, we create health literate people and societies. We know that health literacy is content and context specific, so the knowledge and skills differs depending on what aspects of health we are talking about, whether it's about diseases, diabetes and cancer, for example, or it's about preventing risks like alcohol or smoking, or if it's about staying healthy. So for each of the different focus areas, health literacy will be content and context specific. I usually compare it to a chameleon. Like health literacy is like a chameleon reflecting the color of the environment and the purpose that is being discussed. So a nice little campaign from Australia explains health literacy in a very simple and easy way, where you see here that health literacy is about your own health. It's about how you care about health information, how you're able to take shared decisions, and communicating with healthcare professionals and taking action, and eventually creating good health for yourself and your family. But it's important to know that health literacy has 2 components. One is the individual capacity, and the other one is the support that we get from the health literacy environment. So again, it's not only what the individual person knows, but also how we as systems, as healthcare providers, design health information, how we communicate with people and patients, what kind of strategies and policies that are in place, and how easy it is to actually access health facilities. So our colleagues Paka and Ratsons, they have developed this model from 2010, where they talk about the importance of people's skills matching the complexity of systems. But what are the challenges? Well, our research shows that in Europe, at least among 17 countries, health literacy differs within and between countries. And you can see here that it's almost 50% that have limited health literacy and those that have actually sufficient and excellent health literacy. We know that healthcare system differs in all the countries, so it's difficult to compare the country by country, but still it gives an indication about how people perceive it to find and understand and judge and use information to take decisions in everyday life. And this research has been done as part of the European Health Literacy Survey. Within our data, we also see a very strong social gradient. So if you are poor, if you have poor health and poor education, there is also a very high risk of poor health literacy. And the risk factors associated to low health literacy is your socioeconomic status, your level of education, ethnicity and minority, for example, also the way you use health services and how you validate your own health. So we know that there are risk groups, we know that there are risk factors influencing and amplifying the impact of health literacy. Low health literacy is big business because when you have a mismatch of people not finding the health services, not applying to health instructions, then it has an economic consequence. And from the UK, we know that 10 to 20% of health budgets are attributed limited health literacy. From the US, we know that United Health Group has estimated that low health literacy can be attributed to 1 million unnecessary healthcare visits and an additional cost of $1 billion. So this is why I call health literacy a big business. It's also impacting human lives, because if you lack access to health services and lack of clear communication, it leads to a silent epidemic. It's taboo to talk about, but we do know that it creates inequity due to this strong social gradient. So I call on you to bridge the gap. It's really time to bridge the health literacy gap. And we can do this by designing health literacy strategies and policies related to health literacy, evidence-based health literacy policies and strategies. It is eventually a choice, our own choice. And we know from our research that health literacy accelerates sustainable development, and it's part of sustaining not only the health of people, but also the planet. So this illustration shows the donut model by Professor Rayworth from the US. In the inner circle of the donut, it's about the basic needs, where health is one of the basic needs that people have. And the outer circle is her view on how we overuse resources and cause climate problems. But if we transfer the donut model to the health sector, we see the same. It's very difficult in some countries to cover the basic needs of health, and in other countries we overuse resources in ways that are not helpful and sustainable. So what can we do about it? We know from health literacy research how important it is to meet people's needs, not by providing one-size-fits-all solutions, but actually tailor solutions so that it really matches people's needs and concerns. And you can see it here, how it also adds to equity. And we have highlighted how important it is to design our services and our healthcare in different ways. And this is a model from United States called the Health Literate Organization model, the 10 attributes of health literate organizations. And they highlight how important it is that leadership buy in to improve health literacy, that patients and consumers and clients are integrated into evaluation procedures so that things can be changed if not done correctly. So including consumers and meeting the needs of everyone, no matter which ethnic group, which age, which gender, and so forth. And design the material and information in ways that people understand. So these attributes can help enhance our outcomes. And we see this from our research, that it's actually possible to enhance outcomes. I want also to highlight the fact that it's not only organizations that need to improve, we also need to adopt a systemic approach to health literacy. And you see that health literacy organizations in this diagram is just one of several factors. We also need to get the political buy-in, the leadership buy-in, and invest in digital health technology, provide enough resources to actually make behavioral change, and also make sure that we keep the human value in the center and engage in interdisciplinary and intersectoral approaches. So one example from Scotland is a national action plan on health literacy, which is called Making It Easier. And the first one was called Making It Easy. This is the second one called Making It Easier. And it builds on the evidence on how healthcare professionals can make a difference. I have myself been involved with the Council of Europe, an organization supporting more than 40 member states, more than 40 countries, on how health literacy is really relevant for sustaining human rights. And you can download this guide for free, and it builds on good practices and new research on how to integrate health literacy as part of research, practice, policies, and education. So it's important to monitor population health literacy, because only by monitoring and measuring health literacy we are able to see what kind of differences we can make, and also where the gaps and opportunities are. And we need to start early. So we see more and more countries adopt health literacy strategies and invest in health literacy research in schools, for example. This is one document you can also download for free, where we explain the health literacy research on how to promote health literacy in schools and communities. And then it's a given to invest in digital health literacy also from an early age. And this is one of the main issues where I've been supporting the World Health Organization on making sustainable and accessible systems for patients and consumers and citizens to join. And it's very clear that there is a very strong now policy buy-in from the World Health Organization and its member states to enhance digital health for all. So I hope you can help build capacity, not only among our colleagues in the health sector, but also at any other workplace. We are advising health literacy as part of corporate agendas, so investing in occupational health and work programs, but also in schools, in primary care, and communities, so that everyone has a chance to develop their full potential. So this is an example of a report you can download by Economist Impact that we supported. And Economist Impact has also given or shares an analysis of the economic impact of health literacy around the world. So much research also focuses on helping people to navigate complex systems. It's again about not only blaming patients for not being able to understand the information we share with them, but actually design wards, design hospitals, design primary care facilities in a way that makes it easy for patients to understand and join the services and follow the guidance that is provided. We work with organizations engaged in professional development, together with also patients organizations. So this is very much to tell that whatever research we do as academics need to be made available for patient advocates, made available for professionals to integrate as part of their daily life. Otherwise, we have not succeeded. Publishing our research in publications is not enough. I truly believe we also have an obligation to share our knowledge as part of plain language so that it can actually enhance the way we work as part of everyday life. And the evidence of health literacy is growing. This is our International Handbook of Health Literacy, where we collaborated with more than 100 colleagues around the world to gather health literacy evidence, and you can download it for free again to stimulate your work and find inspiration. So in my last part of the presentation, I want to share with you that health literacy is not only an academic topic to research, but it's really a global movement on the rise. You can see here how the increase is happening in the academic sector, where more than 2,500 publications on health literacy was published in 2000, and it looks like it will be even more for 2023. We have seen an integration of the policy mandate to use health literacy as a lever for change. We have a draft resolution from the World Health Organization for member states to act. There is a guide called the Solid Facts Health Literacy book. We have training material on health literacy and NCDs. We have developed training material on brief intervention as part of primary care. And I hope a lot of the research that you're doing on health literacy will also informing new policies and new practices. And one way we can do it is to work together, and this is why I'm here today as president of International Health Literacy Association, where we bring researchers together with decision makers and with practitioners and with teachers teaching health literacy in different schools and universities, because only by meeting like you do today in your conference, we can actually change the situation. And I'm very privileged to be part of several of these groups, one as president of International Health Literacy Association and as chair of Health Literacy Europe, as an advisor to the Asian Health Literacy Association, and member of several national health literacy boards. So I encourage also Indonesia to start thinking about how can you mobilize and work together, because that's important to take us to the next level. So I hope to see you next year when we host our Global Health Literacy Summit with the topic called Health Literacy for People and Planet. We might also meet in Vietnam, where the next Asian Health Literacy Conference is. And you can also join the webinars of African Health Literacy Network. They just hosted their first national health literacy conference recently, and they will keep posting about new developments there. So to me, health literacy research is very much a factor of how we can facilitate empowerment, because doing research is not alone is not an end in itself. We want the results to make a difference and one way is to facilitate empowerment. It's about using our knowledge that we gain from research to speak up. And despite the turbulent and uncertain times we live in, we see that health literacy matters for economy, in politics, for the environment, for different population groups as part of stronger societal systems. It matters in the media where we talk about the infodemic and disinformation and misinformation, and it's very relevant as part of education and the developments of new technologies. The future is health literate. I truly believe the future is health literate. And why do I say this? It's because I know that you are here, because we shape it. The health literacy future is not something that just happens to us. It's something we shape. And with the evidence and the research that you are bringing about and the investment in health literacy of the decision makers and policy makers, I'm sure we can bring it together. We know it can be done. We saw the major change that the pandemic brought about, the COVID-19 pandemic brought around. And if you help take the lead and join the health literacy community, we are able to enable and empower people and shape conducive environments. To me, you are the true health literacy champions. You are the one that choose to explore and investigate all facets of health literacy. And I'm proud to be here and support you. And I look forward to hear about your next venture when you do health literacy research. Face the challenge, be the change to bridge the gap. Thank you so much.
There's a video from Christine Sorensen. Unfortunately, I'm sorry, Christine Sorensen cannot join in the question and answer because she's in the flight. My conclusion as moderator is health literacy is a wide area in human life. We should make a measure about health literacy in the community. Maybe such as plastic literacy, that's our topic yesterday. We can measure people how they make decision related plastic waste, and the result we can make social engineering related how we can make a behavior change related plastic waste. There's some kind of sample that we can do in the health literacy. If the audience interest and also want ask some question or make collaboration related health literacy, Faculty of Health Science already has ASEAN Health Literacy Association Country Office Indonesia. All of us welcome to ask question and also come to us to make question or explore more about health literacy. I think that's all for the presentation today. As moderator, I say Alhamdulillah. I'm sorry if I have many maybe misspell or some that is not convenient to you. I close this session with Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Once again, thank you, Ms. Annie, for guided we to plenary. So, ladies and gentlemen, next on our agenda is the moment we have all been waiting for. Of course, we can wait since last night, right? Bukan ya, kalau biasanya kita kalau nunggu dari malam gitu kan ya. Oh enggak, dari tadi pagi. Oke. Next, we will immediately announce the best presenters for ISWOPHA 2023. So, aku minta ditemenin dulu ya. So, I will invite Mrs. Nurjana. nggak usah.
Saya yang bacain. Okay. Actually, we have 13 parallel session with more than 19 presenter online and offline. Yeah, and they are all have present their result perfectly, beautifully, and share the knowledge, the experience to the audience online and offline in this ISWOPHA 2023. And I thanks to all the participants, all the oral presenter, online and offline, for such a very great job in their research, in their study, and hope we can do collaboration. I joined some of the parallel session, and there are many discussion, warm discussion in the session, and I think after this conference they can continue to make a collaboration in research and study. So we come to the best. The best, yeah. Actually, all the best. But this is based on the what is it? The penilaian dari juri, yeah. It's calculated from the value from the moderator in every plenary session. So I will announce the third best oral presentation come to Bapak Guardian Yoki Sanjaya from Universitas Gadjah Mada. Yeah, is there Bapak Guardian online? Yeah, I saw him tomorrow here, but maybe he back to their campus. Okay, this is the third best oral presenter. Okay, congratulations Pak Gugu, is from the Medical Faculty of Universitas Gadjah Mada. And then the second best presenter, oral presenter, comes to Bapak Muhammad Abdul Hakam.
From Dian
Nuswantoro University. Actually, they also from the head office of Semarang. Congratulations, Bapak. Is he joined the? Okay. And then the first best oral presenters come to Ibu Martini from Universitas Diponegoro. Yeah.
Okay. That is three winners.
Ini enggak, ibu-ibunya, bapak ibunya, ada enggak di Zoom? Okay. Congratulations for all best presenter. I hope all presenter also continue their work.
Of course.
Yeah, their work and do the best. I know all the best presenter in this ISWOPHA 2023.
Okay, thank you, Ms. Nurjana. So finally, we ask to you to officially announce the official closing of the conference today.
Okay. Not my Dean. Me? Yeah. Okay, before we close this conference, I would like to invite our guests, our speakers here to make some special closing remarks for us. Maybe Pak Suki first. So, Pak Suki? Maybe for Pak Suki, can you make like something to say, briefly closing remark.
Okay, all right. Yeah, thank you so much. I'm privileged to be here together with so many distinguished speakers. Professor Amanda, thank you, Bu Dian, for inviting us to be here. And this first time I attend this ISWOPHA conference, and I feel that it's good to bring from multidiscipline people, multi-talent, multi-skill. I think today a lot of world issue is very systematic, systematic issue. So it cannot be just solved by one aspect of, have to be collaborative. So I think continue, look forward to the next event again. Yeah, I think we need to have more meeting like this, to bring all people together, to solve the crisis. Thank you. Thank you for all.
Terima kasih Pak Suki, matur nuwun ya for your support, for your insight for us, for participants. And then our distinguished speaker from Australia.
Thank you so much. And what a wonderful conference, hey? I'm a marine scientist and I learnt so much. And I think one of the really important things that I take away from this conference is that environment is so important when it comes to human health as well. And we need to think, just like you said, collaboratively and connectedly. And I was really pleased when I walked into the keynote presentation earlier today to see also conversation and discussion happening about behaviour and human behaviour and behaviour change, because it's going to take all of us and it's going to take a concerted effort to manage ourselves and our environment into the future. And it's great, this conference has been wonderful because it's bringing many different disciplines together, just like you say, and multidisciplinary research is essential for us to solve the problems that are facing us and our environment and our society. So I'm really encouraged by the theme of the conference, by the interactions, by the presentations. I didn't get to see many. I'm sorry, I was running a workshop. I hope the workshop was useful, but I really think that it is so nice to be face to face. Yeah, after so long online and Zoom, and we get so sick of it. So thank you for the invitation, and I loved it, and I hope to come back, and I hope to see you all again in person and face to face. So doesn't finish here. Maintain your connections, your collaborations, the people that you met while you're here, people that are interesting, develop lifelong friendships and lifelong learning. Yeah. Thank you, and thank you so much.
Thank you, Ms.
Thank you, Professor Amanda. Yeah. Yeah. So
last but not least, what is your hopes, ma'am, for to ISWOPHA 2023?
Oke, ya ini harapan nih katanya. Harapannya apa ya? Mungkin kalau harapan mungkin teman-teman dari peserta kali ya. We got a lot of knowledge, a lot of experience from the experts, from the professionals, And actually we are from a faculty, basically from faculty of public health, So our mission is how to change the behavior, the human behavior, to be a healthy behavior. You are the expert on your particularly subject, particularly knowledge, but maybe we can do collaboration between scientists and then behavioral scientists like us, some of us. So I hope after this conference we can do like a more fruitful discussion, and then continue, keep in touch, and do communication, and let's change the world. Thank you.
Okay, thank you, Ms. Janet. To continue new collaboration, new knowledge yang tadi begitu ya, Ma'am. Okay.
Yeah.
Okay, thank you, Ms. Jana, once again. So, ladies and gentlemen, let us give applause once again. Okay.
Because we have no rehearsal from this moment. So by this time officially we close ISWOPHA International Seminar on Workshop on Public Health Action 2023. Alhamdulillahirobbilalamin. Thanks to God, thanks to all participants to attendance in this conference. Thank you, thank you.
Okay, and with the end of the ISWOPHA series of events, and today is also the end of our meeting. Gitu like that. Thank you very much, Miss Nurjana. We would like to thanks to keynote speakers today, researchers, committee, and many thanks also to the sponsors like that. I'm Indira Majestika and Miss Nurjana say thank you and see you.
See you. But last not least again, I would like to thanks to our committee, our students that have a hard job, good job for the conference successful. Please come to the front, the committee, kan panitia bisa foto bersama dengan para speaker. Iya, nanti peserta boleh foto juga ya, boleh ya. Panitia.
Okay, to our committee.
Actually, they have hard work for this conference. So, mari Mas, Mbak, yang di belakang.
Okay, once again, thank you for joining with us in ISWOPHA 2023 with the team Ensure Healthy Life supported by Sustainability Energy, Environment and Healthy Literacy in the era of Society 5.0. So, ladies and gentlemen, to all participants, see you at ISWOPHA 2024. Bye-bye!